Hi, and good afternoon, everyone, and welcome to today's program, Case Conversations on Contraception Use and Preferences in Females with Sickle Cell Disease. I am so excited to be here with everybody today, and my name is Dr. Tami Singleton. I'm the Division Chief of Pediatric Hematology and the Director of the HTC at the Mississippi Center for Advanced Medicine. And I am certainly incredibly passionate and very interested in the advancement and the optimal treatment and management of both women and girls with sickle cell disease. And again, I am absolutely thrilled to have an opportunity to moderate today's program. Next slide. The Foundation for Women and Girls with Blood Disorders mission is to ensure that all women and girls with blood disorders are correctly diagnosed. And I want to add in and have the opportunity to be diagnosed, to be optimally managed at every life stage. I wish I could scream this from the rooftops. To this end, we aim to provide education to healthcare providers on the medical consequences and the unique issues for women and girls with blood disorders. Next slide. So, since its inception, the foundation has focused on realizing its vision through these objectives, as you can see displayed here. Next slide. We have a renowned and engaged board with deep expertise in treating women and girls with blood disorders. It is an absolute honor just to be in the presence of these folks. Next slide. So we have a few housekeeping details. So to ensure the best sound quality during our program, all attendees will be muted, right? We all have issues with that. Technology is great, but sometimes we mess it up. So everybody's gonna be muted. So, but you will have the opportunity to participate in a question and answer session with Doctors Roe and Nero. So please make sure you don't go anywhere, as well as myself at the end of the program. You can also submit your questions during the program or after the presentation portion via the chat box in your control panel on the right side of your screen. And we will address them during the question and answer session at the end of today's presentation. We'll certainly keep an eye on that. So I would like to introduce Dr. Andrea Roe, who is the Assistant Professor of Obstetrics and Gynecology at the Pennsylvania Hospital, Perelman School of Medicine at the University of Pennsylvania, and is the first author on the paper we'll review today. Dr. Alicia Nero, who is the Assistant Professor of Hematology and Oncology at UT Southwestern, she specializes in pediatric adolescent sickle cell care, and she'll also join us for the program. So please, we are so grateful to have them join us today for this important discussion. And let's take a look at the disclosures. So our faculty have the following disclosures to report, as you can see. And then next, we'll kind of flip through our accreditation. So these next few slides will detail our accreditation process. In support of improving patient care, this activity has been planned and implemented by CMED and the Foundation for Women and Girls with Blood Disorders. CME will be provided to physicians and nurses, and a follow-up email will be sent to all attendees explaining how to obtain the 1-hour CME CE credits for the program after its conclusion. So let's hop to the pre and post-test questions. So we always have to have this part, right? Like this is so important. So to assess knowledge gain, we will be asking 2 sets of questions during the webinar. One set before the presentation and then one set after. So this is really important data. The data will be entirely aggregated and your results will not impact your ability to earn CME credits, but it's just important information for us to have. Okay, so you can take a look there. So receiving credit, in terms of receiving credit, you will receive, remember, an email after the program's conclusion with the evaluation and details for CME credit. Okay, so we're taking a look at this poll, right? So let's see that. So, all right, very good. So let's take a look at this very quick poll and just take a moment to answer the poll question on your screen. All right, Did the poll question? There it is. There it is. Do females with sickle cell disease use less contraception, use contraception more, less, or about the same as the national sample? So go ahead and let's try that out. Select one of the following: more, less, or about the same. All right, fantastic. I love this. Yeah, so we're going to have a lot to debate and talk about at the end of this, right? Like this is something, right? Yeah. We have a lot to talk about as to the whys associated with that. Okay. So, let's go ahead and begin our pre-test questions. All right. So, we're going to start with, so please make sure, that you go ahead and we're going to go through the questions and then please press submit. So, what do females with sickle cell disease cite as their most important contraception or contraceptive preferences? Effectiveness, control over contraceptive use, lack of side effects, or all of the above? Go ahead and quickly select your option and hit submit. Fascinating. Okay. We're going to have, like I said, I think we're going to have a lot to talk about. All right. All right. So what percentage of females with sickle cell disease report a history of VTE, venous thromboembolism? So 10%, 30%, 50%, or 70%? In your experience and to your knowledge, what percentage of females report a history of VTE? Interesting. All right, let's take a look at the next question. Very interesting.
Those were actually all free.
That's it?
Yeah, for now.
Okay. All right. Fantastic. All right. So now we're going to turn the call over to Dr. Roe for her presentation and remarks. I can't wait to hear everything. I'm excited.
Perfect. Thank you so much. Hi, everyone, and thank you so much to the moderators and to the Foundation for Women and Girls with Blood Disorders. And especially I have to give a shout out to Kim Roque for all of her assistance preparing for this, and for this wonderful opportunity to talk about contraception and sickle cell disease. So I'm sure everyone on this webinar has their own stories about patients with sickle cell disease and pregnancy, and I'm really looking forward to hearing those during the discussion section. As an OBGYN, I've become attuned to the particular challenges surrounding unplanned pregnancy and sickle cell disease during my time working on labor and delivery, where I've seen females with sickle cell disease hospitalized over the course of their pregnancies with pain or blood clots, sometimes with preterm delivery. And now as a subspecialist in family planning, I've really seen much more of the complex interplay of contraception and sickle cell disease, and the specific risks and benefits that hormonal contraception may carry in the setting of sickle cell disease. So to begin to understand this a little bit better, we decided to perform an assessment of contraceptive use and preferences in a modern cohort of females with sickle cell disease. And so here's the paper that we'll be discussing today. It's being published in the journal Contraception, and I'd like to take a moment to thank my co-authors, whom you see listed here. Hopefully, there is it. I need to go forward. Let's see if that's working. There we go. Perfect. So first, a little bit of background. As you all well know, the life expectancy for individuals with sickle cell disease has lengthened dramatically in recent decades, and people are increasingly living to reproductive age. And so, of course, it's wonderful that many females with sickle cell disease have the opportunity to pursue pregnancy, but unfortunately, this remains a super high-risk state. And females with sickle cell disease are actually 10 times more likely to die in pregnancy than those without sickle cell disease. And so optimally, pregnancy in sickle cell disease is something that is planned and monitored by specialists. However, pregnancies among females with sickle cell disease are very often not planned, and I want to make sure that I note that this is not something that's unique to sickle cell disease. Many pregnancies, about half of all pregnancies, are unplanned, and so this is true of people with sickle cell disease as with the general population. But in sickle cell disease, this can have really severe maternal and fetal health consequences. And so thus, contraception can be a really critical tool that allows females to control whether and when to become pregnant. But very little information exists, especially in the modern cohort, on the contraceptive choices and preferences of females with sickle cell disease. So we undertook this cross-sectional survey of reproductive age females with sickle cell disease who attend the outpatient hematology clinic at the Hospital of the University of Pennsylvania. We recruited patients between 2019 and 2020. We reached out to 95 female patients with sickle cell disease who met our criteria, and 48 agreed to participate in the survey. The mean age was 31. The vast majority of this group identified as Black or African American. In terms of important medical history in this group, participants reported an age at menarche of 14. Half of this group were Paris. Most reported regular periods every 4 weeks. Approximately half reported vaso-occlusive pain with perimenstrual timing, either just before, during, or after their menses. And nearly 1/3 reported a history of venous thromboembolism, either deep vein thrombosis or pulmonary embolism. So before we get to the results, I wanted to put this up as a reminder of the currently available contraceptive methods for anyone who might not be thinking about birth control on a daily basis as I do. So this is organized by in tiers of effectiveness. So at the very top, you can see the long-acting reversible methods of contraception. These include the progestin arm implant or Nexplanon, and the copper and progestin intrauterine devices. And then you can also see next to those the permanent methods, which include tubal ligation or self-injectomy and vasectomy, which are obviously surgical procedures. And then next you can see the shorter acting hormonal methods, including the progestin injection known as Depo-Provera, the oral contraceptive pill, the transdermal patch, and the vaginal ring. And then after that, you have barrier methods, and then finally, fertility awareness and calendar methods. So our primary outcome was contraceptive uptake, and we compared this to data from the National Survey of Family Growth, which is where we get all of our estimates of contraceptive uptake and method mix in this country. And the participants, you'll see on this image, the participants in our study are shown in the blue bars, and the national sample is shown in the orange bars. And any significant differences between the groups are highlighted by an asterisk on the y-axis, or p-values on the right of the bars. And the most stunning finding is at the very top. We found that the most common contraceptive method that our cohort used was actually no method at all. Less than half of our sickle cell disease group used any form of contraception, and this was significantly lower than the national sample. After that, you can see the contraceptive methods are listed in order of frequency of current use among our cohort. So the most common methods were the progestin injection, or Depo-Provera, followed by on the screen on the IUD. They were used at the same rates. And I mentioned earlier that there were 2 types of IUD, either copper, which is called the Paragard, or hormonal, of which there are a few different brand names. And all of these IUDs that our cohort reported were the hormonal type. The other interesting differences here are that the significantly lower rates of uptake of permanent contraception and the oral contraceptive pill in our group of females with sickle cell disease compared to national rates. And this is a summary of the remainder of our results. So again, this group used contraception at significantly lower rates than the general US population, 44% versus 65%. And then our next finding came from the fact that we gave participants a list of about a dozen contraceptive characteristics, and we just asked them to rate how important each one was to them. And we learned that their biggest priorities were effectiveness, control over use of the contraceptive, and lack of side effects. And for me, this highlights a potential conflict between patient preferences and the existing methods. So for example, if the most effective methods are also the ones that require either surgery or a device insertion procedure, as you saw on the previous slide where the tiered effectiveness slide, for a person who wants both effectiveness and control, it makes me wonder how they're navigating their contraceptive choices and what they might be sacrificing. And then finally, we also asked about sexual activity and participant goals. And we found that over half were currently sexually active with a male partner, and that the majority felt it important to avoid pregnancy in the next year. The majority also felt a sense of control over whether to become pregnant. And I find this area really interesting. And one part of it that's so interesting to me is that the degree of overlap among these issues is actually not as obvious as you might think. So in other words, the people who answered yes to these questions are not all the same people. And so it raises a lot of questions for me, and I think some opportunities for discussion among us. But in general, I think how people with sickle cell disease manage their reproductive autonomy is just not straightforward, and I think that we need to really better understand contraceptive decision-making among females with sickle cell disease. So these for me are the take-home messages of this study. We showed a shift in contraceptive method mix compared to studies from the 1980s, and this was in line with some other recent work by Diva Sharma and colleagues, and shows a movement away from oral contraceptive pill use and toward progestin methods like the injection or Depo-Provera and the progestin IUD. We also queried for the first time these contraceptive characteristic preferences, and participants reported effectiveness, control, and lack of side effects as the most important priorities to them. And I also wanted to highlight the prevalence of venous thromboembolism in this group. Nearly 1/3 reported this history. And this is important because a history of VTE precludes the prescription of estrogen-containing contraception and is therefore a really important part of an individual's history, especially with regards to their contraceptive options. And then finally, I wanted to highlight that half of this group reported perimenstrual vaso-occlusive pain. And Dr. Sharma also found this and showed that individuals can really distinguish dysmenorrhea or menstrual cramping from pain that is specific to sickle cell disease. And this is another important part of someone's history that we should be paying attention to. And it may be that hormonal contraceptive methods can be used to improve perimenstrual sickle cell pain. So after, I think, our post-presentation poll, we wanted to open this up to the group because we really want to hear your questions and also comments, experiences. I'm here to learn from you all as well. And so some questions that I'm really interested in discussing and hearing the answers to are, what are you seeing in practice? What are your patients using for contraception? What do you see as their priorities as they're choosing methods? I'm also really interested to know what barriers patients and providers like you are encountering as you discuss and consider contraceptive methods. And then finally, what are your suggestions for research areas in order to better understand the relationship between sickle cell disease and contraception? Looking forward to talking with you about this more.
All right, guys. So are we going to hop into the poll really quickly, or we're going to talk about, we're going to do Q&A first?
Nope, we got the poll first question.
Okay, all right, great. I just
Right
want to
on.
make sure. All
No
right.
worries.
All right. I love, pre and post tests. Okay. So once again, do females with sickle cell disease use contraception more, less, or about the same as the national sample? More, less, or about the same? Go ahead, go for it. Mm-hmm. Yep. We're similar. Our less went up. Let's take a look at the next question. What do females with sickle cell disease cite as their most important contraceptive preferences, effectiveness, control over contraceptive use, lack of side effects, all of the above. All right, we kind of stayed the same. I really want to talk about that one. You know, I have some questions at some point, have my own questions. Okay, let's hop into that last question. What percentage of females with sickle cell disease report a history of VTE? Go for it. 10, 30, 50%, 70%. Looks like our numbers are kind of, yep, we're kind of coming in, you know, in a similar fashion, sort of as before. Okay. Gonna look and see if I can see my chat. Remember, on the right side in the chat box, you can type in questions there. So please feel free and go ahead and do that. As we're kind of getting that started, I want to kick off one question slash comment if I can. So
You're the boss, you can.
All right. So, you know, one of my favorite clinics is our sickle cell transition clinic, and that's the place and space where I have historically had an opportunity to talk to a lot of our, you know, adolescents, young adults, and adult females. I actually see a lot of adult patients well beyond the age of 25, you know, as we call ourselves those lifespan providers, even in that transitional space, and you know, serving these women and girls, right? And as we talk about, we have a lot of conversations about goals, and if your behaviors are mirroring or really reflecting your stated goals when we talk, especially when we talk about contraception. And so, you know, when I asked throughout the question to a lot of our patients, you know, are you, you know, kind of actively, or would you like to have a baby now, in the next 6 months, or in the next, you know, year or two? And if the answer to that question is no, it's typically no. Sometimes it's yes. Well, you know, what are you considering? What are you actively sort of doing? If you are sexually active, are you sexually active? Yes. Okay, so what are you doing to actively achieve that goal? And a lot of the time, sort of as we saw with the study, a lot of the time the answer to that is no. And so then we have a more detailed conversation. What I have heard, and of course this is anecdotally, more often than anything else, yes, the patients want birth control that are effective. Yes, they want something that would be sort of easier for them to use and safe. But the thing that sticks out like a sore thumb, like the real truth, as I like to say, is they're super concerned about side effects, and the biggest of which would be weight gain. And I just think that's a real life barrier. And have you heard that, experienced that? You know, what are your thoughts about that?
Everybody's worried about weight gain, sickle cell people and people without sickle cell, I think. So although this has not been investigated specifically in the sickle cell population, there's really no good data to support that any hormonal method of contraception increases your weight, with the exception of Depo-Provera, I would say. So, you know, if you interviewed people and followed them out, after they start the oral contraceptive pill, you'll find some people gain a little weight, some people lose a little weight, and by and large, most people are the same. The problem with really long-term longitudinal studies with birth control is that everybody tends to gain weight over time. So if you're looking at somebody who uses a hormonal method of birth control over 2 years, 3 years, 5 years, most people are going to gain a little bit of weight. And so you really need to do comparisons, and those are a little bit harder to study. But there are some studies of that, especially with Depo, that do show that there can be some weight gain with Depo-Provera, though it's not usually a dramatic amount of weight. And so I would consider this more of a myth than a reality, this concern about hormonal birth control causing weight gain. But what I always say with patients is that, I can't guarantee this one way or the other. The only way we'll know kind of how this method will affect you, for better or for worse, is to give it a try, and that, all of these are reversible, can be stopped at any time. So, there are significant benefits to birth control, especially prevention of pregnancy, but among other things. And so I say, I don't think that weight gain should be the driving factor in the decision to use or not use contraception.
I agree, absolutely. Weight gain shouldn't be the driving factor, but they talk about it a lot, a lot.
I know.
Right? They talk about it a lot, to just kind of to have a keep it real conversation. And so I'll throw another kind of scenario out there, and I think that probably a lot of us experience this, especially those of us who are, really kind of seeing a lot of the sickle cell patients. So the reason why I think that weight gain comes up as a focus of the conversation is sort of just as you mentioned, that Depo is often a go-to.
Mm-hmm.
And we're in looking at the risk in terms of thromboembolism or thromboembolic disease in patients, not only that just generally have increased viscosity because they have a hemolytic anemia, but we're talking about hemolytic anemia along with sickle cell disease. And so we're typically a lot of times steering patients to non-estrogen containing contraceptive methods. Just want to hear your thoughts a little bit about those options and maybe how some of those conversations go when we have those patients, and should we really have more open conversations about lower dose estrogen containing contraceptive methods. And then I'm going to hop to the questions that we have coming in the panel.
Yeah, sounds great. I think that we don't have a lot of data on this. And so I think a lot of this discussion is going to be really helpful to see what people are doing. I'm very curious to know what the hematologists here are recommending or not recommending for their patients in terms of, avoiding estrogen or being cautious or not. I think we know that baseline rates of VTE are shockingly high. Even in this cohort, this pretty young cohort, the mean age was 31. So I think that the risk of VTE just needs to be at the forefront of people's minds. And one thing that I'm not sure about is whether that is at the forefront of the minds of OBGYNs or PCPs, who may be the people who are prescribing birth control. I personally would use a lot of caution with estrogen. I think that there are other methods of birth control that are great, that are effective, and don't carry that same risk of VTE that may be, synergistic or may precipitate a VTE in a patient who hasn't had one before. That said, we don't have numbers on this, and so I can't say what the rates are, whether the rates of VTE on a new user of estrogen containing birth control are higher. But I would suspect that would be the case. It just seems logical, but unfortunately we don't have the data to really show that. But I think in the interest of being cautious, it seems like, why not try something else first if that's possible? And then, of course, for somebody who already has a history of VTE, then it really just takes the estrogen-containing birth control off the table.
Right.
And with regards to your bringing up Depo specifically, Depo is really interesting because, you know, there was a study from a while back that showed that Depo reduced the frequency of sickle cell pain in females with sickle cell disease. And I don't know, I'm very curious, and I ask you all whether that's something that you are considering when you either might recommend that method to people, or is that something that is like in the archives and not really thought about? I'm very curious about that. And the other thing to remember about Depo is that, number one, you know, even though it is a progestin-only method, there are some data to suggest that it can increase your recurrence risk of VTE in somebody who does carry that history. So that's something that, in general, when I have a patient who has a history of VTE, I'm, you know, calling up the hematologist at our institution to sort of talk through what the risks are and whether Depo would really be the safest next strategy for somebody. And then the other thing to think about with Depo is that over time there can be an impact on bone density, and that's, you know, a longer term effect and one that is reversible in the general population, but we don't know exactly how that works and what the effects are for people with sickle cell disease. So just another thing to think about with Depo specifically.
So actually there was a question from the audience that, and you answered it. And that was, you know, surrounding concerns or reports in the literature that Depo may sort of predispose you, especially in this population, to a VTE, and especially, again, thinking about those patients who have a history, right, of a previous event. And so because of that, right, that risk, as well as again the concerns about what people look at, right, the vanity part of all of us in terms of weight gain. Sometimes we're kind of teetering, you know, on the edge of, you know, should we or shouldn't we, in terms of making recommendations to use Depo or not. What are you seeing? And I'm going to circle back to sort of like crisis and Depo and some of my thoughts, and maybe if there's a question specifically about that. But what are you seeing in terms of other methods? How about are you seeing an increased use in IUDs in patients in general, and just in your experience, and maybe even in sickle cell patients? I know that we're using them a lot more in our clinic, but what are your thoughts?
I think it's definitely being used more. So if you compare this to, you know, there's a contraceptive study from the 1980s, and IUDs were not really being used at that time, but also the progestin IUD had not come out at that point, or maybe had just come out. So I think that we're definitely seeing a trend towards increased IUD use. And then in this study, we saw higher IUD use compared to a national sample. And so I do think that there is a trend overall, just sort of a secular trend with time, of IUDs becoming more popular over the last couple of decades. And I suspect, but I do not know if this is actually true, but I suspect that it is being turned to among the sickle cell population for all the reasons that we were just talking about, which are that, you know, it doesn't have estrogen in it. It doesn't carry sort of the higher load and potential risks of Depo-Provera, which again is still a great form of birth control, but just, you know, we just need to be thoughtful about any method that we use. And, you know, the other sort of advantages of a progestin IUD include reduced menstrual flow, potential decrease in dysmenorrhea that can be potentially helpful, I would imagine, for somebody who is suffering from those symptoms and side effects of just a normal menstrual cycle. So I definitely think it's increasing over time, and it does seem to be disproportionately popular in the population of females with sickle cell disease. And what I really want to know is why. Is it, you know, are people coming to that on their own? Are they being recommended that by hematologists? I'm very curious.
So I think that maybe the answer to that question sort of lies within this next question, right? Because when we're talking about patients with sickle cell, and because of the risks, we're sort of staying away from estrogen containing contraception for the most part. And then what are our options? We're dealing, primarily with depo, as we've discussed, as you pointed out, now the IUDs. And then, of course, there's the oral form, but that can be associated with some issues, right? So the question here is there a downside to only using progesterone for contraception is one part. And then, especially in the oral form, given some girls don't want an IUD or an injection. So yeah, is there a downside to using progesterone only, containing contraception, and then especially focusing on like the oral form if we have women or girls who don't want the injection and are not interested in the IUD?
Yeah, so I think the downside is always just the potential side effects, or which for progestin only methods are primarily alterations in the bleeding pattern. So basically, I think what you're asking is why not prescribe a progestin only pill as opposed to a combined hormonal contraceptive pill that has estrogen? And the differences are, the big difference is in the irregularity and the breakthrough bleeding that you can have with a progestin only pill. Not everybody has it, but it is pretty common. And that's because the estrogen is the stabilizing force in the combined methods. And that's what really kind of helps give cycle control, and the progestin only pill, you might not get it with that method. That said, I think it's still worth trying. And I think that, but I'm not sure for somebody who is coming to you with irregular bleeding, let's say a teenager who's coming to you with irregular periods, painful periods, the usual go-to is a combined hormonal contraceptive pill. And so that's the question. I ask you, is there any downside? I mean, the question is, you're weighing a potential inability to control the symptoms that a patient is coming to you to help with, versus this potential increased risk of VTE. So I think that, without having firm numbers on how much OCPs would increase that risk, it's hard to answer that question. It's going to be based on all of our cumulative anecdotal evidence at the moment.
Absolutely. So I want to, kind of put a bookmark there, because there are several questions surrounding, the use of contraception, patients that are symptomatic, vaso-occlusive crises, that kind of thing. But I just want to go back and kind of touch on, I think we've answered some of these questions. So there's a question here, of all the progesterone methods, it disappeared. Okay. So of all the progesterone methods, isn't the risk of depo causing thrombosis the highest, especially in this population? I just wanted to throw that out there. I think that we've touched on that, but that's something that we know that this is a higher risk population. And I think that we've already kind of said that there is certainly some association with VTE with depo, the injection. And so
yeah, I think it's that there's some data to support it. I think it's just a little bit more ambiguous, I would say, whereas the other progestin only methods are more clearly not associated, if that makes sense. So I think with depo, you're just saying, we just aren't sure. I know that there are clinicians who hesitate, especially in the setting of a history of a VTE.
Exactly.
But I still think that, it is not a slam dunk in the same way that estrogen increases your risk of VTE. So
Gotcha.
just to be clear about that.
And sometimes I'll go ahead and throw in this comment too. Sometimes, real world, real talk, when we're treating our patients with sickle cell disease, we have to look at life and what's ideal, and then what can the patient actually do. And from a social standpoint, psychosocial standpoint, what can or can't be done. And, if we have pills as an option, we have patients who are taking other pills Sometimes they're very frank and honest about not being able to keep up with the regimen of an additional pill. And then there are the risks associated, as you mentioned, with breakthrough bleeding or issues with breakthrough bleeding. There are other issues in terms of if you can't take it, on time, every day, what are the risks that are associated with that? So then we circle back to our next two options, right? We talk about the injectable form, so depot, and then we're back to the IUD. So with that said, there was a question that I wanted to ask or kind of throw out there, and just kind of bear with me because the questions are rolling in and I'm having to kind of scroll back up. But so someone asked, is anyone prescribing estrogen-containing contraception to women with sickle cell disease? You talked about the risks, but I just want to throw that question out there. I'll say, for me, not on purpose. Not typically on purpose. Sometimes I will have patients who maybe I haven't seen for a while. They were seen by a provider and started on estrogen containing. I don't typically do it on purpose. Do you see that, on your side of things?
I think at my institution, there is a strong preference to avoid estrogen-containing contraception. There were still people, as you might have seen in the study, who used various estrogen-containing methods, but it was definitely the minority.
Right.
But I don't know if that is like an institutional skew or a regional skew. I cannot speak for, other places across the country, and I'm actually very interested to know. I wish we could have added that to the poll questions.
Right. And I think that it is a question I think that would be kind of cool for us to ultimately have some more information on. Again, I don't think that it's not necessarily just unique to your center. I think that probably pretty much across the board that we'll probably stay away from it, but there may be instances, right, and reasons as to when or why we may need to do that. Just want to throw this in. Oh, there goes my question again. And so this says 11th. Okay, so there was a small study, comment here. There was a small study that shows that Depo-Provera decreases pain crises, but that, and the audience member stating, says, to my knowledge, again, it hasn't been replicated. We don't know the mechanism. And is it possible that menstrual suppression with some of the new methods also have that the decrease in vaso-occlusive crises is associated with them? We need more research. So I think that goes back to my bookmark, right? Like that's something, and what I know that certainly I'll comment here and say, we have a lot of women and girls and adolescents with sickle cell disease, and I think it is, that whole inflammatory response that's associated with, starting, menstrual bleeding, starting your menstrual cycle sort of for the month. I would see a lot of sort of quote unquote breakthrough vaso-occlusive events associated with that. And that would really drive us, in addition to other reasons, to want to have some control. And so that kind of brings me back to, as you mentioned earlier, well, what methods of contraception, or what, as we refer to it here in the South, as what methods of hormonal therapy, can we use to help our patients with sickle cell disease when that is an issue, when there's a lot of just that kind of PMS associated with it, but that in turn also sort of triggers a vaso-occlusive event. What are your thoughts on that when we need to control symptoms, when we're looking at those progesterone only containing options versus even thinking about something that has estrogen?
Yeah, great question, because I do agree that, the best ovulation suppression that we normally turn to would be those combined hormonal contraceptives. So if we end up taking that off the table or deprioritizing them because of the VTE risk, then you're saying, what of the remaining options can we use instead? And the answer is a little bit unclear because it depends on what the patient is presenting with, I think. And it's also unclear because we don't know the mechanisms of action of some of these processes that I think the question asker was referring to. So for example, if we think that there's something about the hormonal fluctuations that precipitate some of the pain symptoms, then what you would want to do most would be to suppress those fluctuations. And so that would be best done with either Slind, which is a newer progestin-only pill that does have some ovulation suppression, more so than its progestin-only pill predecessor called Micronor. And then Nexplanon, which is the arm implant, also has a lot of ovulation suppression effects. However, if the thing that we want most is to reduce bleeding and lighten bleeding, and maybe we think that it's the menstrual flow and the cramping and the dysmenorrhea that somehow precipitates the pain crises or pain episodes, then it may be that a hormonal IUD would be the best bet, because that would be your sort of best chance at achieving amenorrhea and not having any bleeding at all. However, it doesn't reliably and consistently suppress the hormonal fluctuation of the menstrual cycle. So I think it depends on what the most concerning symptom is, and what the patient and the provider are most eager to try to remove from the situation. But it's hard because we don't know the mechanisms of action here, and we don't know, and so because of that, we don't know necessarily which one is the quote unquote best progestin-only method to reach for. And then Depo-Provera is also an extremely good suppressor of ovulation and the hormonal fluctuation. And so I think that if that, and also is very good at achieving amenorrhea. So I think that that's something that we can't take off the table. And especially if, the limited data that we have is actually surrounding Depo and hormonal contraception, that oral contraceptive pills that contain estrogen. Those are the ones that have been shown to decrease sickle cell pain frequency. As old and as limited as those data may be, it's the only thing that we have. So I think we need to keep that in mind too.
I want to share this next comment because I'm like, yep, this is absolutely right. I experienced this exact same thing. Listen to this one. It says, I tend to lean towards progestin only. I work primarily with adolescents with sickle cell who need management of birth control. So the majority of our patients are on Depo. The problem for us comes up when they're unhappy with Depo. I've been looking for GYN providers who have an interest in adolescents and the placements of IUDs in an age-appropriate way. We have to do have a lot of conversations to make sure that happens, right? So possibly with some sedation to make sure the experience is less traumatic at this age. I can say bingo, yes, yes, and yes. For me as a sickle cell provider, I've done this like the same thing. The GYN providers that I've worked with have been great in terms of making recommendations to make it less traumatic in an age-appropriate way. I've offered, little oral anti-anxiolytics. I've had a couple of other suggestions from some GYNs. I've come across some, if I'm saying this appropriately, that they use miso. Is that right? Kind of thing. So any comments or thoughts surrounding that? Because that's a statement that so many of us who treat sickle cell patients, we're experiencing.
Yeah, totally. I think that one thing that I would say about, well, two things I think that can help with the difficult experience. I mean, for somebody seeking contraception who may never have even had a pelvic exam, having an IUD inserted is a leap. And so, but to be honest with you, some people do amazing with it. I'm always shocked when I'm literally showing somebody a speculum for the very first time in their whole lives, and they are able to get through an IUD insertion. I mean, it's sort of a miracle. But obviously that's not 100% of the time, and for good reason. People can have really difficult experiences with it. I think two things that can help that are tangible. One is experienced providers, people who are putting in IUDs like day in and day out. I think have the ability to make patients feel really comfortable sort of have a lot of techniques to use when cervical dilation may prove to be a little bit difficult for, a teenage nulliparous cervix, for example. I don't think meso is a cervical ripening agent that you can use prior to an IUD insertion. It's not recommended routinely in the literature, and so I never use it as a first line. I almost never use it, to be honest with you, but I know some people do use it in a situation where they had like a failed IUD attempt, and so they might add meso and have a patient come back for a second trial. But I think a couple of other things that make it easier to place is in an experienced provider's office, they also often will have an ultrasound at the bedside in case there is any difficulty with the IUD insertion. So I do think that there's something about sort of a nulliparous, young patient cervix that can sometimes make it a little bit more challenging. And so provider experience and having the tools ready can be super helpful. The second thing is that there's good data to show that a paracervical block for nulliparous patients can reduce the pain of IUD insertion. And that is not something that has been taken up by GYN providers across the country. As you know, with all scientific data, it takes a long time for it to disseminate and even longer for it to be incorporated into practice. And so even though it sounds completely terrifying to have a shot of lidocaine injected around the cervix, we have good data to show that that actually improves the pain experience for nulliparous patients. And so we use that routinely, and I think it's helpful.
Excellent. Oh, look, I'm so excited. There's so many great questions. We're going to try to power through a couple
in advance to whoever we don't get to. There's so many questions.
I mean, they're wonderful. And yeah, okay. So just a quick comment. So I hear there's a comment about Depo Cat 2 by the MEC.
Yes.
Yep.
Category 2 means that it is safe, and so I think this person is just reminding us that it's actually that the CDC, which if for anybody who doesn't know, the CDC puts out recommendations every few years called the US Medical Eligibility Criteria, where they actually go through a lot of different chronic diseases and medical conditions and basically rate the safety and risk of different contraceptive methods. And so category 1 and category 2 are like the green light categories. And then category 3 and 4 are the ones where 4 is basically this method is contraindicated, and 3 is kind of the risks outweigh the benefits. And so it's a great resource to look into. And so I think this person is just reminding us that despite all of our reservations about Depo that we have talked about, the data are really not enough to actually push the CDC to say that it's not recommended. Sorry, that was a lot of double negatives. So what I mean is that Depo is still category 2, which is a green light category for people who have a history of VTE.
Absolutely. Okay, so look at this one. Is there any data or any signal for IUD placement precipitating a vaso-occlusive pain crisis? And this is given the data about perimenstrual pain crisis, or any particular precautions we should counsel our patients with sickle cell disease about prior to IUD placement? I'll let you, yeah, it's a good question. I'll let you answer it, and I'll I can piggyback.
My answer is I don't know. That has not been studied, I don't think. And I would say the pain control, I would say things that I would do to reduce pain would be the same things that I do for other people, which are ibuprofen in advance or some kind of NSAID in advance of the IUD insertion, hydration, and then that paracervical block that I just told you about, and also just being really nice and keeping people really comfortable during the procedure. But what do you all recommend something on your end before your patient goes to get an IUD?
Yeah, so I have not had any issues with it precipitating a crisis. I always use an anti-anxiolytic. And I haven't had any problems. And it's just my clinical experience. I give them instructions. I provide them with something orally. I make sure I talk to the GYN to kind of let them know, make sure we're on the same page. We give it, as they're kind of pulling up into the office, for the procedure. or the insertion, and it's kind of worked like a charm for us. I haven't had any, vaso-occlusive issues with any patients thus far, and I use a lot of IUDs. Okay.
Yeah, I will say that when I do procedures in the OR for people with sickle cell disease, like uterine aspirations, for example, which are still minor procedures that we can do in the office, I've heard anesthesia just say hydration and keeping patients warm. So even though it's a procedure that's less than half an hour, they use a ton of blankets, a bear hugger, things like that to keep patients really warm.
So I hear minority women have a long history of contraceptive coercion in the US. How do you balance progestin-only options in this population with their initial preference for avoiding, do you say LARCs?
That is my question as well. I think that we cannot avoid or ignore the fact that nearly this entire sample consisted of Black females. And this history of contraceptive coercion and reproductive coercion and forced sterilization is not even history. I mean, it's recent, it's current in some ways. So I think that it's a real, it's a real problem, and I have to believe that that is part of the reproductive and contraceptive decision making for these people. This was a survey study, so obviously we couldn't confirm that, but I think that has to be the case. In terms of balancing it, I think that you just have to be really mindful of this history, and there are studies that, of course, that show that OBGYNs will participate in this contraceptive coercion and have bias. There's a really fantastic study that came out of UCSF that showed that a patient presenting with the same history and desires, but who looked, who presented in a different socioeconomic status or was a different race, got recommended different kinds of birth control options. So, I think the first step is awareness that this is something that is a current problem still, even though you hope that forced sterilization is not something that is happening as much. And it's just something that you have to be really aware of in the patient encounter, where you have to just say, at the end of the day, here are all the options. Let me tell you about the pluses and minuses, but you have to have it in a patient-centered way. So if the patient says, no way, no how, I'm never going to get a LARC, then, then that's the end of the story, So I think you just have to have an awareness of it, incorporate it into your discussions, and sort of have an awareness as you're going through the methods, and really have these kinds of contraceptive counseling sessions be patient-led.
Look, the questions are on fire. I'm gonna hop to this one real quick because you might be able to say yes or no, or I don't know. Oh crap, it moved up. Hold on a second. If the patients in your cohort were 98% Black, do you know the percentage in the NCFG?
Yeah, so great question. So I think that's sort of getting at, I think I see what you're getting at. The National Survey of Family Growth is a nationally representative sample, so it is not 98% Black, and so there are racial differences, of course, in the makeup. And so it's possible that the group that we surveyed with sickle cell disease more closely resembles a Black-only US cohort, but we didn't actually do that comparison.
All right, let's see if I can get this last couple in. You talk about how the stats for sickle cell disease compare to the general population. Did you compare any or compare to similar socioeconomic populations?
We did not.
Yeah, I figured you could answer that quick. Okay, let's see. Everybody's loving the questions. This is fantastic. And this is one maybe we can both kind of chime in to kind of start closing things out. How frequently do young women with sickle cell disease want complete menstrual suppression because they have menorrhagia or heavy menstrual bleeding that exacerbates their baseline anemia? I know that's something that I am very frequently concerned about. I don't know, if I have patients who are, but that's an issue. So it says, I also
Are you
wonder
saying?
about, yeah, so I have a lot of patients who have a baseline hemoglobin 7 to 8. Because we have severe menorrhagia, we're having hemoglobins, 4, 5, and they're becoming symptomatic because of it. And so the piggyback to this, which is right in our wheelhouse, right, as the foundation. I also wonder about whether people think about bleeding disorders, especially von Willebrand's disease, may be underdiagnosed in this population, because we're focusing on sickle cell disease and not other hematological issues that may be going on. You know, I'll start off and say yes and yes to all of that. Amen and amen, right? So women with sickle cell disease, if they're having severe menorrhagia, as a group, as hematologists, as we're working together with the foundation, with you guys, our GYN colleagues, absolutely, we have to and should always consider, could this patient also have an underlying bleeding disorder, like von Willebrand's? And we definitely run into issues with severe menorrhagia with a worsening anemia and having, very acute symptoms, when patients before, had a chronic anemia and may not necessarily have those same symptoms. What are your thoughts about that from your perspective?
I don't think I have anything to add to your perspective. Because you're seeing the general population. I'm only seeing the people once they come for referrals.
Right. And so, yeah, that is yes and yes, that is an issue. And when we're working with and consulting with you guys, or our GYN colleagues, it is super important, because sometimes we have a more acute issue on the table with a history of severe menorrhagia. But yeah, we absolutely always have to or should think about working our patients up. But I do think that that's a point. It's probably not thought about enough. And it may be missed from time to time in patients that have sickle cell disease, also thinking about an underlying bleeding disorder. Okay, I'm gonna sort of end with this, maybe 2 more questions. I'm stretching it, I know. But I'm stretching it, but it's so much fun if you can indulge me. Because as a hematologist, I think that I may be in this wheelhouse too, like not knowing the answer to this. It says, okay, I apologize, I'm a hematologist and I have a patchy recollection of some things from an OBGYN perspective. So can you explain briefly how pregnancy prevention is achieved, if not through ovulation suppression? I think I know the answer to that, especially with IUD,
Oh,
IUD.
yeah.
Right, and I guess.
So why are we talking about all these methods that don't have ovulation suppression, and are they really legitimate birth control? Yeah, of course. So, right. So the traditional, combined hormonal contraception suppresses, the hormones in the brain that tell your the ovaries to release eggs, etc. So that's ovulation suppression. And if you don't have an egg that's released, you can't get pregnant. The alternatives are, things that don't necessarily touch that HPO axis, but act more locally at the level of the GYN tract. So thinning the endometrial lining to make it implantation not possible, and then thickening of the cervical mucus to prevent sperm penetration are the most common methods for that. And then, for example, one thing that's more specific to the copper IUD, which does neither of those things, is that it releases these copper ions that are, we think, spermatotoxic, or causes like inflammation of the inside of the uterus.
Excellent. You guys, the questions have been amazing. The comments are phenomenal. We have to do this again. Like this is, yeah, this has just been so great. And I think that, I know that you guys probably feel, the exact same way. So thank you so much for submitting all of your questions. Doctor, thank you so much for your input. Thank you for your partnership, your insightful comments. We have to do it again.
Thank you. This was so fun. I put my email address in the chat for anybody who we might not have gotten to who wants to continue this conversation. offline.
Thank you thank you so much. I know I'm going to email you. Again, again, Dr. Rowe, thank you. The foundation is absolutely pleased to provide this program at no cost to attendees, sort of just as a reminder, right? So this has been amazing, an amazing opportunity, right? We even get credit for this. I mean, and it was fun. So you'll receive your evaluation immediately following the program, guys, for all of the attendees. So please complete it, and we'll send the information regarding your CME, CE credits. Again, we want to say a huge thank you to all of you for your attendance today. We look forward to your future participation in foundation programs. This is the best foundation ever. It doesn't get better than this. I know I'm kind of biased, but I just think we, this rocks. Like it's so awesome. So our next case conversation session is slated to be held in December. I can't wait. So please check the website for more information. I think we need to slide one more in too, like and talk about more of this stuff. So I'm going to put a plug in for this. So thank you to everybody. Have a happy Friday and a wonderful and safe weekend. Thanks to the foundation. Thanks, guys.